No.
Hello, can I start?
Yes, sir.
Okay. Good evening. My name is Dr. Shakti, and we are going to continue with our revision series. And today we'll continue with the cardiovascular system, part 2, and we're going to finish off cardiovascular system. So I want you to these questions. You can see one question, analyze the pathophysiology of hypertension, so it's like a long essay, including the mechanism leading to its development and systemic effects. So you have to write a note on what is hypertension, what are the causes for the hypertension, what are the effects of it, and what are the derangements in body's mechanisms in regulating your blood pressure that leads to it and how you can treat it. So under all these points, you can cover this. Then discuss the role of kidney. So kidney is mostly important for long-term BP regulation. That is one thing. And describe the impact of atherosclerosis. Don't see that question a lot, at least at your level. But since it's given here, I'll just briefly go through it in case a question comes. Then explain the physiological basis of MI and the mechanism of angina. So usually a case scenario will come from cardiovascular system, and there will be MI or angina, and you'll have to make a diagnosis. And then a structured essay will be there with multiple questions regarding angina or some BP regulation question or coronary circulation. So that is how these questions can frame out, or like this, they can ask as a short essay. And then we have other question like, again, stable and unstable angina. What are the difference? These two things we had already covered it last time. So just to have an idea of how questions appear, you can just take a look at it. Okay. So again, as usual, I'm going to first give you some questions that are going to come and we'll be discussing about it. So you can see fetal circulation. A short note on fetal circulation can be asked, or they'll ask like, what are the changes that happen in fetal circulation after birth? The first thing about fetal circulation, you have to understand the blood which is coming from the placenta, carrying your oxygenated blood. So what is carrying the oxygenated blood is coming from the placenta through the umbilical vein. Okay, so a vein is carrying the oxygenated blood because it is going to the heart. Now this, when it is going, since it is oxygenated, and it needs to pass through the liver, and it should not mix with the portal circulation. Otherwise, what will happen? Deoxygenated blood and oxygenated blood will come to mix together. So you need to avoid that. Directly went in through the inferior vena cava and go into the heart. And for that, we have the ductus venosus. So instead of it coming down and going into and mixing with the pulmonary circulation and through the hepatic vein, whatever is coming, instead of that, it bypasses that and goes directly to your heart through the ductus venosus. And then what it does, once it goes to the heart, we're still talking about the oxygenated blood. The oxygenated blood which is coming in will come and directly pass through a hole between the right atrium and the left atrium. This is foramen ovale. So through the foramen ovale, it is gonna go directly to the opposite side. Okay, and then it goes to the opposite side, comes down, and it gets ejected out through your left ventricle and goes up into the aorta. And in the aorta, it predominantly goes into your head and neck region and the arm. So head, neck, and arm is receiving your oxygenated blood, which is required for your survival. Okay, so head and neck and the arm is receiving the oxygenated blood, which is coming from the umbilical vein, ductus venosus, inferior vena cava, directly through the foramen ovale and ejected out. Now, once it goes to the head and neck region, now a deoxygenated blood is coming back from there, which will come through your superior vena cava like this. It's coming through the superior vena cava, coming down. And instead of mixing with that, the flow is in such a way that this is gonna go down into the right ventricle. And the blood which is going into the right ventricle usually should go to the pulmonary circulation. So on the way to the pulmonary circulation, since lungs, the pressure over there is not adequate, lung is not expanded. So we have another ductus arteriosus, which bypasses it and instead goes into this. At which point, what is going to happen is it is going to come into your lower body. That is how your rest of the body, especially the legs and all, will now receive blood supply. But it is somewhat of a mixed blood. Okay. And this, which is going down to the rest of the body, through that, it is now going to go back to the placenta through the umbilical artery. And then it gets oxygenated and then comes back. So it's a question of how is fetal circulation? These are the various things that you need to cover under this question. Now, if the question is, what are the changes to fetal circulation after delivery? So this again is a model which we were talking about. From this model, exactly the same thing we were talking about. In a newborn, what is going to happen? Suddenly, the lungs are going to expand. Okay, so the baby takes the first breath. So now whatever is coming from the body, from the right atria. Okay, from the right atria, usually it goes to your left atria through the foramen ovale. Okay, now the problem is earlier, because the lungs were shut down, the pressure difference between right atrium and left atrium were different. Now what happens? Because the lungs are opened up and whatever is going into the lungs now, since it is reaching this area and that is coming here and whatever else was coming from here. Now that means in the left atria, the pressure will be much higher than earlier, resulting in a flow in this direction and along with some mediators which are released like histamine, bradykinin and all, it will result in closure of this foramen ovale. Now foramen ovale is closed and then it will be somewhat similar to how you see in adults. Foramen ovale is closed, lungs have opened up. Only thing is this ductus arteriosus, since now the left ventricle, which is pumping. Okay, so that is still connected to your ductus arteriosus. And since the pressure is higher here now, there will be a slight reverse flow for a short while. And eventually this also shuts down. And then your ductus venosus also becomes a ligament eventually. Okay, that these two processes take time. Foramen ovale immediately closes and the ductus arteriosus also eventually closes. Till then, a slight backflow might be there because of the pressure difference. Okay, and then this is the final adult model you must be knowing already. Another question, write a note on autoregulation of blood flow. So what is autoregulation? It is the maintenance of near constancy of the blood flow. Okay, for that, one of the important things is this should usually be done by the system itself. So if there is an area, when you say auto-regulation, generally we mean that if there is an area without any external factors, innovation, things like that from outside, this one system by itself is able to regulate whatever. That is what is called auto-regulation. When you talk about auto-regulation of blood flow in your regional circulation, in some way, the blood flow in any part of the body can be regulated. If it is increasing, decreasing, almost near constancy of blood flow can be maintained despite changes in blood pressure. So usually this is done by in the acute setting. sudden changes in BP and all, the differences with respect to vasodilators and vasoconstrictors which are released locally. In the long term, it can result in changes in the size and the number of blood vessels. So in the long term, the blood vessels can change. In the short term, local vasodilator, vasoconstrictor, metabolites and all are more important. So there are two theories. Okay. So we have a metabolic theory. Metabolic theory is talking about how, when there is raised BP. Okay. So initially just consider BP is less. BP is less. One of the things that happens in the body is metabolites are released. When BP is less and not enough blood flow is received, then there is not enough oxygen. And because of that, there will be more vasodilator metabolites which are released. Now that resulted in vasodilation, which means now there is going to be more flow, or directly there was raised BP, whichever it was. Now, because of that, suddenly the oxygen and nutrient supply is increasing, and it is able to wash out the vasodilators, which means now it will go back to the initial state where it will reduce its flow. So can you see how, in two instances, it is able to either increase, decrease based on just the amount of metabolic byproducts which are accumulating or being washed off. So that is metabolic theory. Another thing is your myogenic theory. So this is talking about especially an increase in the BP. When there is a stretch because of the increase in the BP, there is vascular depolarization. Exact mechanism is not known, but they are postulating that there are some sort of tethering with the help of cytoskeletal elements to ion channels, which results in calcium entry. Now calcium is entering, the muscle contracts, the smooth muscles contract. So this kind of prevents excessive stretching. Okay, so when you talk about this, there are two things I want you to talk about. One, this diagram about blood flow versus rate of metabolism, blood flow versus the oxygen saturation. So you can see that when the oxygen saturation reduces from 100 to 25, you see that the blood flow increases 3 times. In the same fashion, when your rate of metabolism in the body is increasing, the demand is increasing, rate of metabolism is increasing, that by itself can result in almost a 4 times increase in the blood flow. So one, oxygen is reducing. That by itself will increase the blood flow. Okay, or the metabolism is increasing inside the body. That will also increase the blood flow. So this is what we're talking about, metabolic theory. Okay, so again in acute setting, it's basically the vasodilators, oxygen, nutrients, all of that which mediates it. Okay, then when changes in pressure are there, the metabolic theory, myogenic theory, we talked about that. Then there are certain local factors, endothelial factors also, like how endothelium can release nitric oxide if you need dilation, okay, or prostaglandin, endothelin, things like that can be released. In the long term, how does it modify blood flow? By neovascularization. If not enough blood flow is there, it will release substances so that more of neovascularization is there. For that, one example is vascular endothelial growth factor. Okay, other ones are also there. They generally increase. And on the other hand, it is said that if oxygen is there, that can reduce. A lot of oxygen is there, that by itself can reduce. Okay, and just a few humoral factors also, like angiotensin, vasopressin. Okay, all of these can result, and of course, epinephrine, norepinephrine. All of these also can result in some degree of vasoconstriction. Okay, and some degree of vasodilation and all that to mediate Okay. So next set of questions is about blood pressure. This is a very important set of questions, often repeated. If you're going for the exam, never go without studying your regulation of BP. Okay, some question is gonna come from this. So regulation of BP like this can come as a, just like this, a 5-mark question. This can come as a 10-mark question also. Okay, so based on the marking system, you have to write points according to that. Okay, separately, short-term regulation can come as a short note. Under short-term BP, baroreceptors can also come as a short note. So say, for example, for 3 marks, they ask baroreceptors. They ask short-term regulation of BP for 3 marks, or they ask for 5 marks. If they ask short-term regulation for 5 marks, you write about baroreceptor, you write about everything else, 5 marks is there. If they ask for 3 marks, then now you have to reduce how much you have to explain, because baroreceptors by itself can come as a 3-mark question. There's a lot to write in that. Okay, so according to the marks, you have to write in accordance. Then long-term regulation. Usually intermediate regulation by itself will not be asked as a short note per se, but if a question of regulation of BP comes, what I noticed is most of the students skip the intermediate regulation. They only talk about short-term and long-term. They do not write about intermediate regulation, and you are losing marks for that. Once when I was correcting papers, almost everybody, like 90% of the students, did not write intermediate regulation, and they lost marks because of that. Okay, so please pay attention to also include the intermediate regulation. So under regulation of BP, 3 things. Short-term regulation. Under short-term regulation, you have to talk about your baroreceptor, chemoreceptor, CNS ischemic response, low pressure receptors. Under intermediate, we talk about stress relaxation, inverse stress relaxation, capillary fluid shift, and the renin-angiotensin mediated vasoconstriction. Don't get confused here. This is just the vasoconstriction. Under long term, the renin-angiotensin mediated salt and water reabsorption and aldosterone. Okay, so this is the framework. Even if you do not know anything, you write this framework, at least you'll get a lot of marks. Okay, short term, intermediate, long term. So again, you can see the timing of these. Okay, baroreceptors, chemoreceptors, CNS ischemic, all of this starts within seconds. And then in between stress relaxation and capillary fluid shift, and this green color renin angiotensin vasoconstriction. So that takes few minutes to hours. And much later, the renin angiotensin mediated salt water reabsorption and the aldosterone mechanism. That takes few days. Okay, so this is how regulation of different types of BP is happening. Now, if a short note on rapid is coming, you write about all of these things at least. Okay, we'll discuss about all of this. Again, baroreceptors by itself was a question. Please remember that. So if a question of baroreceptors coming, what are you going to write? 1, what is baroreceptors? These are stretch receptors in the tunica adventitia. Okay, they are branched, knobby, coil, intertwined ends of certain myelinated nerve fibers. Okay, so this is present in areas of your carotid sinus, okay, or your aortic sinus. And from here, your 9th cranial nerve. From here, your 9th cranial nerve. And from here, your 10th cranial nerve is taking the impulse. So when you talk about it, it has a range of its activity from 50 to 200. And at 100, the mean arterial BP is where it is best active. Maximum effect is over there. Okay, beyond 200, it's not that it's not active. The change won't be there. It won't increase beyond that. Okay, so you can see here how at different BPs, as the BP is increasing, how the activity is increasing, and how at 50 there's still some sort of activity, and this activity has some sort of differences between the different phases. When a sudden change is there, that is when most of the activity is there. Okay, between the different phases only you can see here changes. That is a dynamic property of your baroreceptors. Okay, now baroreceptors, again, what it is, where it is, then talk about its range, talk about baroreceptor resetting, because in a chronic increase in BP, in 1 to 2 days, the mean arterial BP resets to that elevated BP. Okay, so it's no longer trying to keep it at 100, it might try to keep it at 120. So how does this work? We have rostral ventrolateral medulla, caudal ventrolateral medulla. Okay, so the rostral ventrolateral medulla is that area where sympathetic activity is there. Okay, to increase BP and heart rate. The caudoventrolateral area is another area next to it. We'll talk about what it does. Apart from that, your cardiovagal center is there, which results in parasympathetic activity through vagus. Okay, so when baroreceptor activity is there, what is going to happen is when increase in the BP is there, impulse is taken, reaches nucleus tractus solitarius, and it will go stimulate the cardiovagal center. What do we need? We need to decrease the BP. So stimulate the cardiovagal center. And you should make sure to inhibit the RBLM. How does it do that? It goes and stimulates the CVLM, which will in turn go and inhibit the RBLM. This is how when increase in BP is there, it reduces the BP. Okay. And in a similar fashion, when there is a decrease in the BP, there is no impulse, the impulse reduces. And when the impulse reduces, it is no longer stimulating the cardiovagal center, no longer stimulating the CVLM, which means the inhibition on the RVLM is no longer there, and RVLM is now free to act. It's very simple. Okay. Next is Bainbridge reflex. Okay. So when you talk about Bainbridge reflex, again, that is your baroreceptors. They're still continuing your short-term regulation. So when you talk about Bainbridge reflex, you should know that, when sudden rapid infusion of some volume is happening. Okay. Or, just by inspiration, you're taking an increased venous return. So any sort of such increase in the return into the heart suddenly results in an increase in the heart rate. Why is that happening? Is through these atrial stretch receptors. So atrial stretch receptors, they are receptors which are low pressure receptors. So apart from the baroreceptors and all that, there are certain low pressure areas where you have receptors like atrial stretch receptors. So they detect it and increase the heart rate to make it move faster along instead of damming in the veins, it results in it moving faster through it. So that is Bainbridge reflex. Then we have chemoreceptors. So when you give substances like, capsaicin, initial experiment was on capsaicin, but then serotonin, veratridine, like this different substances results in activation of chemoreceptors. This is called Bessel-Jarisch reflex. What does it do? There is a vagal efferent. Since it is vagus which is detecting it, the effect of vagus would be bradycardia and hypotension. Okay. And changes with respiration. You just have to think about your Bainbridge, something similar. When inspiration is happening, early inspiration, what is going to happen? Increase in the venous return. Increase in the venous return, stretch receptors are activated, resulting in tachycardia. Okay. Now, late inspiration and expiration, the opposite happens, bradycardia. Now, the reason for this, one is this atrial stretch receptors. Apart from that, just the process of uh, stretching of the lung stretch receptors can also stimulate it, or there are signals which are coming directly from the respiratory areas, which might directly go to areas of your BP control and RVLM and stimulate it. So these are three different reasons which are given. So you can write down all three also based on the marking which is given. Uh, Strawberry waves are waves stream which changes with respiration. That is only about BP. Okay, how BP changes with respiration. Mayer waves are reflex oscillation because the different blood pressure control mechanism between that, some what do you say, some sort of error between them. Error, like whenever we say any signal, okay, in homeostasis, it is never at one point. Instead, it is shifting from one point to another to try to keep it at a value. Okay, all of your different BP regulation mechanisms trying to keep the BP at one mean arterial BP. That is basically your Mayer waves, okay, which is usually around 10 to 40 millimeter mercury, much slower than how you see in strawberry. CNS ischemic reflex. So again, if uh, short-term regulation, you do not have the time to study all of these things. You find it difficult to understand. Study baroreceptors, study CNS ischemic reflex. At least these two you see. Okay, so we talked about 50 to 200 range. Less than 50, CNS ischemic reflex will take over. Okay, its greatest effect is between 15 to 20 millimeter mercury. So one of the things that happens is when there is increase in accumulation of carbon dioxide, either because of decrease in blood flow. So somehow blood flow to the brain is reducing because decreased BP. So decreased BP is there, because of which decreased blood flow is there, because of which CO2 is now rising. That CO2 along with hypoxia has an effect to directly go and stimulate your RVLM to increase your BP. This is what is called CNS ischemic reflex, which is a rapid, powerful mechanism. Now, the thing is, Cushing reaction is a special type of CNS ischemic reflex, where some sort of raised intracranial pressure is there, because of which the blood flow is affected. Okay, so this raised intracranial pressure decreasing the blood flow, resulting in the same things. That is Cushing's reaction. So that is your short-term regulation. Then we have intermediate regulation. Renin-angiotensin mediated vasoconstriction is the intermediate. Then capillary fluid shift. In capillary fluid shift, what happens? Increased blood flow is there, increased BP is there, and the hydrostatic pressure inside increases. Eventually, it will result in stalling forces and net filtration pressure increases, and it goes out, thus reducing what is there. Instead, if capillary pressure is less, pressure outside is more, and that will result in things coming inside. So this simple capillary fluid shift will shift the volume of your plasma and adjust it accordingly. Yes, stress relaxation, inverse stress relaxation also. So when there is high pressure inside, one of the things that happens is eventually that high pressure will make the volume of that increases. The blood vessel, if it is this much, if it is constantly under high pressure, it increases its size. And if the volume is increasing, pressure drops because they're inversely proportional. Okay, so that is one mechanism by which it can again control in an intermediate fashion. So that is capillary fluid shift, stress relaxation. Opposite of stress relaxation is inverse stress relaxation. Then renin-angiotensin mediated vasoconstriction. In long term, we have renin-angiotensin mediated salt and water reabsorption. So what happens is when there is a decrease in the pressure, decrease in the blood flow to the kidney, when juxtaglomerular cells detect it, renin is released. Renin will act on your angiotensinogen, which is released from liver, breaking it to angiotensin 1. Angiotensin 1 will now go through the circulation, reach the lungs, where it is converted to angiotensin 2 by a angiotensin converting enzyme. This angiotensin 2 now will result in a vasoconstriction. This vasoconstriction is what we are talking about in intermediate. Okay. Now, apart from that, angiotensin 2 can directly go and result in your salt and water reabsorption. When salt and water reabsorption is happening, increased volume is there, systolic BP increases. Apart from that, when vasoconstriction is happening because of that intermediate fraction, that will result in increase in diastolic BP. Okay. Now, this is the direct effect. Angiotensin 2 by itself can result in salt and water reabsorption. But angiotensin 2 can also go and stimulate the adrenal cortex to release aldosterone, which can also do the same renal salt and water reabsorption. This is your long-term regulation. So in long-term regulation, this is when BP decreases. What happens when BP increases? This is another part which students do not write. So in regulation, you have to talk about when increase is happening, decrease is also happening. So when BP increases, again, juxtaglomerular apparatus detects it. Renin is not released. Decrease in the renin secretion is happening. Okay, when increased BP is there, increased glomerular filtration is happening, which means more salt and water is coming in, which is detected by macula densa, which will also go and inhibit the renin secretion. Okay, at the same time, increase in the salt and water will stimulate the release of atrial natriuretic peptide. Okay, and again, since the system has more salt and water, osmoreceptors will detect it in the brain, and ADH will be reduced, antidiuretic hormone will be reduced, which means more of diuresis can happen. Okay, so this atrial natriuretic peptide usually are released from A type, B type, or C type in these different areas. Okay, how they act is by dilating the afferent arteriole of the kidney, and they suppress the reabsorption of salt and water in the. Okay, next question is about hypertension. What is, write a short note on hypertension, or what is the treatment of hypertension? So, hypertension, generally we give, according to JMC 7, which is mostly still clinically followed. Less than 120 systolic and less than 80 diastolic is considered normal. Pre-hypertension, 120 to 139, 80 to 89. Hypertension is above 140. Okay. Now, this is the old one. In the new JNC 8, pre-hypertension instead of 120 to 139 is 120 to 129. And just less than 80, doesn't have to go to 80 to 89. Less than 80 with 120 to 129 is considered pre-hypertension. And stage 1 hypertension, 130 to 139. So not from 140, 130 onwards, it is stage 1 hypertension. Okay. And not 90 to 99, 80 to 89 is stage 1 hypertension. So, just write both of this, or stick to one, and whatever you're writing, write this. Because if you follow JNC 8, half of Indian population is hypertensive. So, it's not good to actually, people in clinics still follow this on JNC 7 only. Okay, so that is how to define hypertension. Then, what are the risk factors for hypertension? One, environmental factors. Some sort of, obesity, weight gain, increased dietary, sodium chloride, decrease in potassium. Okay. Alcohol, psychosocial stress, decrease physical activity, sedentary lifestyle. All of that are risk factors for hypertension. Then, sometimes genetic causes are also there. There are rare Mendelian form, but apart from that, it can be polygenic. That is, it's a mix of, multiple genetic with environmental. That is what is called polygen. Most common is like that. Okay, so when you talk about hypertension, majority of the hypertension is essential hypertension. We are not sure of the exact reason. There's no pathology per se. Okay, it's some polygenic form that we see because of multiple factors. Okay, 88 to 95% is actually your essential hypertension. Then apart from that, some secondary causes there, that is either renal problem. Renal problem can be there. There can be an endocrine problem, like pheochromocytoma, Cushing syndrome, primary aldosteronism, anything that results in increase in salt and water reabsorption or increase in the sympathetic activity. And renovascular gain resulting in some sort of increase in renin angiotensin mechanism and thus excess of your salt and water reabsorption, things like that. Okay. And then some miscellaneous ones are there, which like Liddell's syndrome, genetic disorder, where there is increase in the activity of epithelial sodium channels, again resulting in salt reabsorption. So these are secondary causes. And what is the effect of this? Hypertension can affect the heart, the brain, kidney, as well as the peripheral artery. Most common cause of death in hypertension is cardiovascular disease. Okay, so cardiovascular diseases, risk doubles every 20 millimeter increase in systolic BP and 10 millimeter increase in diastolic BP. Can result in left ventricular hypertrophy because why? Hypertension means increase in the afterload. Okay, and they can result in atherosclerotic coronary artery disease, microvascular diseases, cardiac arrhythmia, and all that. Brain, it can result in stroke. It's seen that hypertension by itself can impact cognition, especially in the old. And hypertensive encephalopathy and all can sometimes happen in malignant hypertension. Kidney, again, renal injury and stage renal disease can happen. And peripheral arteries, atherosclerosis, secondary to long-standing hypertension. Okay, so how do you treat it? Lifestyle modification, maintain your body weight, have adequate aerobic physical activity, stop smoking, and improve your diet. Have more fruits, vegetables, less fat dairy products, reduce the saturated total fats, limits the salt intake less than 6 grams per day. Okay, have adequate dietary potassium. So think of all the risk factors and try to limit that and limit the consumption of alcohol. So these are various lifestyle modifications we can do. Treatment wise, what you can give pharmacologically, think of what is BP. Stroke volume into heart rate is cardiac output. Cardiac output into peripheral resistance is your arterial BP. So how can you correct this? You can use diuretics. Diuretics will try to reduce the stroke volume because what does it do? Through urine, salt and water is removed. So the volume decreases. Or heart rate, if it increases, also increases cardiac output and increases BP. So you can try to control the heart rate by giving beta blockers. If peripheral resistance is increasing, that will also increase diastolic BP. So what you can give is some sort of alpha antagonist. Okay, so generally some sort of sympatholytics can be given, which act centrally. So especially you use it in pregnancy and all. Then we have other ones, renin-angiotensin mechanism to block it. Renin inhibitors are there. The angiotensin receptors can be blocked or the angiotensin converting enzyme can be inhibited. Okay, so they will affect either the stroke volume or the peripheral resistance because they result in constriction as well as salt and water reabsorption. Okay, you can try calcium antagonists, which can affect the force of contraction, hence the stroke volume, which can affect the heart rate because calcium is involved in pacemaker potential, plateau potential, and all that. And calcium antagonists can result in decrease in the peripheral resistance. Okay, then direct vasodilators can also increase the decrease the diastolic BP. So this is just an overview of how to understand how we are correcting your BP problems. Next set of questions, the shock. Okay, again, this comes as an essay or parts of a long question. So in circulatory shock, what is circulatory shock? What are the types of circulatory shock? Compensatory mechanism, stages. Okay, so what is circulatory shock? Inadequate tissue perfusion, resulting in some relative or inadequate cardiac output. Okay, so imagine the cardiac output, which is there, that is not enough to give a tissue perfusion. Either it's an absolute problem or it is a relative problem. How can it be a relative problem? That is when the demand is more. Instead of an absolute problem, if the demand at the periphery is more, that by itself can result in a circulatory shock. Okay, maybe it's a normal cardiac output, but since the demand has increased, it is not able to meet the requirement. Okay, so like that, a relative or absolutely the cardiac output is reduced and hence tissue perfusion is reduced. So there are different types: hypovolemic, cardiogenic, obstructive, distributed. Hypovolemic is when you lose volume, like in hemorrhage, okay, some sort of trauma, or through vomiting and diarrhea, or plasma is released through the burns. Okay, all of this are hypovolemic causes. Cardiogenic means heart has a problem and it's not able to pump enough. It gets MI, congestive cardiac failure, arrhythmias like atrial fibrillation, and it's not able to pump enough. Okay, or some sort of obstructive problem where some circulatory problem is affected, because from the right ventricle it has to go to the pulmonary circulation, go to the other side. So in this, some form of obstruction is happening, or while ejection also is not going. Okay, so cardiac tamponade, pulmonary embolism, tension, pneumothorax are all causes where this movement is affected. And last is distributive. So usually this is an example of this relative. So when there is an anaphylaxis, sepsis, neurogenic, the thing is, there is a lot of peripheral vasodilation. Okay, and that vasodilation will result in increase in blood flow to those areas. Okay, so the demand, the runoff is so much high that it is not adequate to the cardiac output which the person has is not adequate. He has to pump more and more to reach that level that is required at the end. Okay, this usually happens either in sepsis, anaphylaxis, or some neurogenic causes. Okay, so when you talk about the stages, it is a non-progressive stage where compensatory mechanisms are coming into the play. It is a progressive stage. In progressive stage, the compensatory mechanisms are starting to fail, because of which some sort of tissue hypoperfusion is happening, and that can result in metabolic acidosis. And progressive will become irreversible when these will eventually lead to some sort of injury, cell injury, multiple organ dysfunction. At that point, there's no coming back. Okay, what are the compensatory mechanisms in non-progressive? This is what you talked about earlier. We talked about BP regulation. Think of BP regulation: baroreceptor reflex, venous systemic response, stress relaxation, inverse stress relaxation, epinephrine, norepinephrine, renin-angiotensin, ADH. Also, just add thirst mechanism. That is a normal thing. A person who's having decreased cardiac output, if it is required, blood volume is less, the person hypovolemia and all, person will feel thirsty and keep drinking. In non-progressive, so again, these are exactly the same things. We already done it in regulation. So I'm just skipping that. Whatever we learned in regulation, you use that. Okay. From progressive, we need to understand differently. So in progressive, what is happening? Cardiac output is less. Okay. Blood flow is less. Nutrition is less. Because of which, what happens? Metabolic byproducts are increasing. Acidosis is happening. Tissue ischemia is happening. Toxins are released. Because of all of this, vascular dilation is happening. Okay. Also, when the brain receives less nutrition, that can affect the vasomotor activity also. That also results in vascular dilation. All of this will result in vascular dilation. Okay. Apart from that, capillary permeability is increased. And now the venous return is decreasing because everything is there in the periphery. And when the heart is also affected, cardiac nutrition is affected, cardiac depression is also happening. Already cardiac output is less. On top of that, now the cardiac depression is also happening, and venous return is decreasing, preload is decreasing. So eventually that will decrease the cardiac output even further. And this is what we call a positive feedback cycle of shock. So this is one example where positive feedback is going to make things worse and worse. Okay, rather than improving it. And you can see how once it reaches a irreversible stage, even if you give a transfusion, the person will eventually die. That is why it's very essential to identify the progressive stage and detect it and treat it. Then next set of questions about coronary circulation. What are the special features of coronary circulation? Methods of measurement of coronary circulation. Okay, so we have the right coronary artery. It has a marginal branch, posterior descending branch. Left coronary artery has anterior descending branch, circumflex branch, marginal branches. Okay. Right coronary artery gives blood supply to SA node, right atrium, right ventricle, posterior part of interventricular septum. The left coronary artery gives supply to AV node, the left atrium, left ventricle, and the anterior part of the interventricular septum. Okay. Apart from this, the coronary artery, arteriole, capillaries, veins, which are going, will go into the right ventricle, left ventricle, and will be drained by anterior cardiac vein, coronary sinus, and finally drain into the right atrium. This is a superficial network. Apart from that, there is a deep network where arteriosinusoidal vessels, arterioluminal vessels, Sebacean vessels are also present. So they are able to form a network. Even if some of them are not working, there's still other ways for it to go through. Now, this coronary blood flow takes 5% of the cardiac output, 225 to 250 ml per minute. Okay. Now, one peculiar thing is normally arteriovenous difference is 5 ml percentage in the peripheral circulation. Okay. Here it is in the coronary circulation is 12 ml percentage. So extraction ratio is much higher. Okay. Now, what are the factors? This is a often repeated question. Factors or determinants of coronary blood flow. So you've got to talk about pressure difference, systolic compression, chemical factors, and neural factors. So when you talk about pressure difference, one thing is during the systole, 120/80 is the pressure you see in the aorta. Okay. In the ventricle, the pressure is supposed to be higher. That is why flow is happening from this side to this side. Okay. So if you look at the pressure difference between the aorta and the ventricles, because for coronary circulation, blood has to go from aorta to these ventricles. So aorta pressure is higher. Okay, so not aorta, sorry, ventricular pressure is higher. So because of that, the pressure difference is going to be -1. So will there be a flow into this? There will not be a flow into this. Okay, to the left ventricle during the systole, there won't be a flow. But you can see because of this pressure difference, it will go into the right ventricle. Again, during diastole, again, blood can easily go because pressure inside is less and outside is a minimum of 80 millimeter of mercury. So this pressure difference is a key component that drives movement during diastole, not during systole in your left ventricle. Okay, so this is during systole is reducing, diastole is increasing. Now between the right and left ventricle also there is a difference. You can see how in the left coronary during systole there will decrease. Okay, but it compensates during the diastole, where metabolites are released and it is increasing much more. But in the coronary artery, it is increasing during the systole and then not much during the diastole. Okay. The local vasodilator metabolites whenever oxygen is less. ATP, ADP, adenosine, this becomes a major component. Apart from that, PCO2, H+, potassium, lactate, nitric oxide, noxine, phosphatine, these are all there. The major component is your adenosine. So whenever there's any sort of hypoxia, asphyxia, intracoronary cyanide injection, all of that can increase the coronary blood flow 200 to 300%. Okay, the neurally, when you talk about acetylcholine, norepinephrine, epinephrine, they can affect it. How? The norepinephrine and epinephrine, they basically act on the alpha-1 receptors directly. What does the alpha-1 receptor do? It results in vasoconstriction. The direct effect of it is to vasoconstrict. Vasoconstriction actually reduces the blood flow. Okay, vasoconstriction reduces the blood flow. But what you have to understand is, apart from local, catecholamines which are released throughout the body, what does catecholamines do through your beta-1? It is going to act and results in increase in the force of contraction, increase in the cardiac output, and increase in the blood flow. Okay, so although there is vasoconstriction, which is the direct effect to reduce the blood flow, because of the indirect effect, there is going to be a increase in the blood flow eventually. And also the peripheral vasoconstriction will also pull everything to the brain and the heart. So although directly vasoconstriction is the effect which reduces the coronary blood flow, because the same neural effect can also increase the force of contraction through beta-1 and hence increase the blood flow. That takes more precedence. Indirect effect takes more precedence. What are the methods of measurement? You can use Sketty method using fixed principle. What they use is nitrous oxide method. You can use radionucleotides like thallium, technetium-99, or you can use coronary angiography with C0. So earlier I was talking about some clinical scenarios. So what is atherosclerosis? It is a chronic inflammatory disease. What are the risk factors? Hypercholesterolemia, especially with LDL. Okay, apart from that, hypertension, diabetes mellitus, cigarette smoking, male, sedentary lifestyle, okay, less HDL. These are all different risk factors. What happens in atherosclerosis? Some sort of endothelial injury is there. That endothelial injury will be responded with some fatty streaks because the person is having hyperlipidemia. Okay, that will result in endothelial dysfunctions. Smooth muscles start recruiting macrophages, activating it. Macrophages start engulfing it. This fat which is depositing, forming what are called foam cells. And eventually, this fibrofatty atheroma develops over here. So, this proliferation results in atheromatous plaque, which can rupture or it can cause decrease in the lumen size. Okay. Next is different cardiac markers for MI. We have troponin, creatine kinase, myoglobin, LDH. Okay, just take a note of how long it lasts, what is the peak, what is the onset, take a screenshot of that and go through this. Okay, so essentially, what is angina? What is MI? So in angina, there is some sort of narrowing of the vessel wall. Okay, imagine this is how it is normally. Now, some sort of narrowing is there. That could be because of atheroma, for example. Okay, now because of that, normally the person is fine. But when he needs to exert and do some extra activity, suddenly through this, the blood flow is not sufficient. This is for the coronary circulation. That is a type of your stable angina. So on effort, it is developing. Okay. Sometimes what happens, some types of angina, even at rest, can be there. That is what is called unstable, but a block has not happened yet. This is unstable angina. Now, if any of this, higher chance for this, but if any of this has instead lumen narrowing along with a block, some thrombus is there, or that erythrometal plaque has ruptured and over there a thrombus formation is happening, then it becomes your MI. So this is the difference between stable angina, unstable angina, and in MI. And MI, the pain is going to be such that it is going to be a squeezing type of pain radiating to the left arm and all. Okay. How do you treat it? You give oxygen, you give morphine for pain, you can give sublingual nitroglycerin to vasodilate. You can give beta blockers to reduce the heart rate. So what you're trying to do is decrease the workload. Okay. You can give stool softeners so that they don't have to strain. And try not to eat any food. Bed rest is required for 12 hours. Okay. Sit just for 24 hours. After 2 to 3 days, the person can start moving around. You can do thrombolysis by giving streptokinase and all. So block can be gone. Okay, you can give heparin, you can give aspirin, clopidogrel, statins and all. You can also give coronary angioplasty or atherotomy to break. Okay, or if nothing works, you can bypass it. So say for example, this is an area which is blocked. Okay, what you can do is take a vein from somewhere else, okay, and put it at these two levels like this. So now the flow will go through this new area and reach it. So that is coronary bypass grafting. So these are different treatment methods. Not often asked, but sometimes I've seen questions. What are the causes of death in MI? One, cardiogenic shock, decrease in the pumping strength, atrial fibrillations, pulmonary edema, and infarcted area can rupture. Okay. Lastly, some questions about your cerebral circulation. What are the factors affecting cerebral circulation? Auto-regulation of cerebral blood flow, methods of measuring of cerebral circulation, treatment of stroke. When you talk about auto-regulation of cerebral blood flow, it usually is in the range 65 to 140 millimeter mercury. There can be a neural cause, metabolic, or myogenic, similar to what we did earlier. Only difference is here, cholinergic vasodilation is there in the brain, which is not there everywhere else. But in the brain, this is there extra. Okay, rest of it is similar to what we done earlier. Now, what happens here is, these are the various factors that affects the cerebral blood flow. Intracranial pressure. Okay, so intracranial pressure, this is where you have to understand a doctrine called Monroe-Kelly doctrine. So the volume of blood, volume of CSF fluid, volume of brain are all equal. Okay, if anything changes, the other can increase or decrease accordingly. So for example, if BP is increasing, okay, if this is increasing, what is going to happen? That will increase the CSF action. And it will not affect the changes in blood. Or if, for example, if CSF is increasing, that will decrease the blood. Okay, so in some ways, there's some sort of a inverse relationship between these. If, for example, volume of brain is increasing because of some tumor, that will decrease both of this. This is called Monroe-Kelly doctrine. So when an intracranial pressure is increasing, that can decrease the blood flow. Okay, then the mean arterial BP and mean venous. So for example, I'm just taking an example. It's based on Monroe-Kelly doctrine only. So mean arterial BP, if a positive G is happening. Okay, when a positive G is happening, what is going to happen? The blood is going to get drained down. And the blood is drained down less. Okay, less blood is going into the brain, which means less intracranial pressure. So now, whatever blood is there, which is reaching here, since IC intracranial pressure decrease, less compression of it, blood vessel, which means blood flow is now regularized. Okay, on the other hand, if a negative G is happening, more blood is going in, more intracranial pressure. Although more blood is going in, since intracranial pressure also increased, it is going to keep it regulated. Okay, apart from that, viscosity of blood can affect it. Local vasodilators, constrictors, and all can affect it. So, for example, increased PCO2 will increase H plus, lactic acid, pyruvic acid, decrease in PO2. All of that can result in vasodilation. Okay. Methods of measurement of cerebral blood flow, again, KT method, positive emission tomography, SPECT, that is single photon emission, computerized tomography, MRI, and special type of MRI called arterial spin label. And stroke, if some sort of a question comes, you have to know only two things. Stroke can be either hemorrhagic or ischemic. Hemorrhagic is when some blood vessel ruptures, or interrupted blood flow by a clot is ischemic. The treatment varies. If your case is a hemorrhagic cause, you give something like mannitol. Instead, if it is a ischemic type, then the treatment will be to break that by tissue plasminogen activator. Okay, so there was a lot to cover. That's why I had to go a little fast. Again, this is revision. So just for you to understand what is important, what to study and focus. All right. So Auricle has its foundational classes. It's got practical sessions also, which have been pre-recorded, live sessions like the one you're attending, and express exam module is there for you to read just before the exam to help you prepare for it. There are one-to-one doubt clearing sessions, hard copy note sets, and there are various question banks which are there of different difficulties. So you can use my code Dr. Shakthinag 20 for discount and subscription. And thank you for watching. I'll start respiratory system from tomorrow.